Good morning. It's very nice to see you all so bright and early. Thank you for coming. I'd like to begin by thanking David and the LFSA for inviting me to speak. It's truly a pleasure and really an amazing opportunity for me to be here among so many giants in the field who I respect immensely. I'm a little nervous, I have to say, but I hope to take a few minutes just to share with you our experience so far with surveillance for individuals with Li-Fraumeni syndrome. I've intentionally not made this talk very data heavy given the early morning time slot, but I will share a few updates since our last publication and just share some overall perspectives that I think we've gained after doing this for so many years. So many of you might be familiar with the Toronto Protocol, as it's called, but really, what this boils down to is an approach to surveillance for individuals with Li-Fraumeni syndrome, one which combines both imaging and some blood tests, but very importantly, frequent interactions with physicians, close attention to symptomatology, and this was something that Dr. David Malkin had envisioned and created, really based on what was known at the time of the prevalence of cancers in Li-Fraumeni syndrome and the risks of various cancers across the age continuum. So the investigations were aimed at trying to detect those cancers that were most common at various age groups. So one group of tests or approach for children and a slightly different approach for adults. And I came on as a young pediatrics resident looking for a academic project to fulfill my training requirements in around 2007 and approached David because I was interested in his research and was very much engaged by his enthusiasm and all of the success he had had so far exploring this field, and so we started this journey together. And over that journey, we decided to evaluate this protocol that we were asking patients to participate in, and went on to publish 2 publications. This one here is the summary of an experience that accumulated over 11 years. I do want to emphasize that although it has been coined the Toronto Protocol, this really has been a combined effort of a number of institutions. Josh Schiffman's group, along with Wendy Coleman and Ann Naumer, have been incredible collaborators, and really this work would not have been possible without the real engagement of their patients and team at the University of Utah. And we also had a very engaged family of Dr. Jonathan Finley's at the CHLA, who very much wanted to be involved. And so together with cohorts from our 3 institutions, went on to study this protocol prospectively. And this publication was a summary of our findings up until July 2015. To that point, we had followed 89 carriers of germline P53 pathogenic variants, and these came from 39 unrelated families. As you may be aware, this was not a randomized study. These individuals self-allocated into surveillance and non-surveillance groups. And the outcomes we were interested in capturing were, firstly, the detection of asymptomatic tumors by surveillance. So would these investigations actually result in us being able to find tumors early before patients were demonstrating any symptoms? And secondly, we were interested in whether a cancer that is detected by surveillance had a better overall survival compared to a cancer that presented symptomatically. And these are some of the results of that investigation. So over that time frame, 59 individuals out of that total group underwent surveillance. And using the protocol, we were able to find 40 asymptomatic tumors in 19 individuals. So many of these individuals had more than one tumor found over time. As you can see from the list, some of these tumors were what we would consider to be premalignant or low-grade lesions. Some of the highlights from this group include a large number of low-grade gliomas, for example, and ductal carcinoma in situ. However, the protocol also was able to detect a number of malignant and aggressive tumors at early stages, and this would include adrenal cortical carcinoma, which is a very challenging tumor to treat in childhood when it is in its advanced stages. Choroid plexus carcinoma is another example here, colorectal carcinoma as well in some of our adult patients. This graph is a summary of which of the surveillance modalities actually detected these tumors. And as you can see just by the colors on the graph that this was not just whole body MRI or ultrasound, that really it was a number of the different components that allowed us to find these various tumors. And looking at these individuals at our defined endpoint, we were able to demonstrate that those individuals who had their tumors, those tumors, I should say, that were detected by surveillance had a better outcome than those that presented symptomatically. Now, I want to come back to the types of tumors, and we received a lot of constructive feedback over the years about the types of tumors that were being detected by the protocol, and a concern about the large number of low-grade tumors. And could this be that we are finding things that probably or possibly would never cause the individual any problems, that maybe that they could live with for a long time? And are we intervening unnecessarily with these tumors? And some reflections on that. I don't think we know the right answers here. But one thing that we can observe from these studies is that low-grade lesions appear to be rare in the non-surveillance group. And in the study from our colleagues in Britain, where they actually had a control group, they actually demonstrated that they did not find any low-grade lesions when they surveyed a control population. So I think we can at least say from that data that these low-grade lesions are probably associated with the germline P53 mutation as a first step. But then, can we make a hypothesis that perhaps these precursors are lesions that will one day transform to a more high-grade or aggressive tumor? And if that's the case, is it in fact a benefit to take them out at an early stage? And this, of course, is an answer that I think we don't know, but one can hypothesize that perhaps the low-grade glioma might transform to a high-grade glioma and present very aggressively down the road and be essentially incurable at that stage. Will these colonic and rectal adenomas one day transform to a colorectal carcinoma, melanoma in situ to malignant melanoma, and so on and so forth? I think the other point that I'd like to make is that there's hopefully going to be a lot of research in this field. I know our group, along with our colleagues in genomics, including Adam Schlein, who you heard talk on the first day, is very interested in the timing of mutational events. What happens after the P53 mutation? What are the sequence of mutations or chromosomal changes that happen thereafter? And can we gain some evidence through these kind of studies over time to support the hypothesis that these low-grade lesions become the high-grade lesions, or refute it? I will also note that low-grade lesions can still be a cause of mortality and morbidity. We've seen that in our practice as pediatric oncologists. I can't comment about some of the adult onset tumors, but certainly I think we have to respect these entities as well as being potentially dangerous for our patients. So on this graph, I thought I would summarize some of the incident tumors that have been detected by the protocol since the publication. So this is since July 2015 up until this point. What you'll see here is a few different color codes, which might not mean much to you, but the green ones here are from our colleagues in Utah, and the black and the red are from Toronto. These red ones are actually individuals who were newly recruited since the last publication. We, in fact, just in Toronto have had another 20 individuals who started surveillance, and so 2 of them over these past 3 years have developed malignancies. So as you can see here, there's overall a representation of what we reported previously, that there's tumors that occur at a range of ages. We have some pediatric patients, some people in their older ages, and some young adults as well. We have a range of both low-grade tumors and high-grade tumors. And we have a range of modalities that were, which contributed to the detection of these entities. I'll show you just a few pictures here. This was a patient of ours who, literally on the day that he was graduating from our clinic at the age of 18 and transferring over to our adult center across the street, had a whole body MRI that demonstrated this mass, which turned out to be a grade 2 chondrosarcoma of the rib. This over here represents a lesion that was detected actually on, this is the only baseline scan. This was a baseline brain MRI of one of our new young girls at the age of 4 or 5, which was resected and turned out to be a grade 2 diffuse astrocytoma. And then one of our teenage patients who we hold very near and dear to our heart, who's had a number of cancers. Early on in life, she had hypodiploid ALL. This was followed by AML, papillary thyroid cancer. At this point, she was diagnosed with Li-Fraumeni, and under the protocol, a few years ago, was diagnosed with an osteosarcoma of the rib. And then more recently developed a myeloid sarcoma, an extramedullary AML, in other words, so a mass that actually was in her abdomen. And very surprisingly, at her young age, maybe even for Li-Fraumeni, a phylloides tumor of her breast. So a few reflections to consider just based on this information so far. I think we can say with a fair amount of confidence that multimodal surveillance can detect pre-symptomatic tumors. I'll talk about false positives and false negatives in a little bit, but just from this, what I've shown you so far, we've been convinced, at least with our experience to date, that we can find these tumors if we look for them. But I would ask you to consider whether on this fact in and of itself is enough to justify surveillance. The fact that we can find them, is that what we should be bringing to our representatives and to insurance companies to say, look, we can find these tumors? Or do we need to do better? And I think the impact on outcome is really the measure that we need to be looking at and reporting to be more convincing and to support the widespread use of surveillance for Li-Fraumeni. And of course, we can look at this in 2 ways. There is the probably more obvious and more intuitive outcome of mortality, and this, of course, is critical. But one thing that I think we need to think about is that even some advanced cancers have an excellent outcome. I'll use the example of stage 4 Wilms tumor in pediatric oncology. It's not a core component of Li-Fraumeni, but a stage 4 Wilms has an excellent survival, as does a stage 1 or a stage 2 Wilms. So the mortality argument probably is not the best one to use in the context of that type of a cancer. But if you look at the chemotherapy and the radiation exposures that people need to achieve that good outcome, I think that's where we really need to focus our attention. And so I'll just say a few words about morbidity. And the point I'd like to make here is that morbidity should really be a primary outcome measure of surveillance in addition to mortality. This, of course, can stem from multiple sources. There's the morbidity of the disease itself. For solid tumors, there is a real potential for surgical morbidity for larger cancers. And of course, the morbidity of adjuvant therapy, so radiation and chemotherapy. And when we think about radiation and chemotherapy, there are, of course, acute toxicities, the ones that are occurring when you're getting those agents, and very importantly, the late toxicities. And coming at this from the viewpoint of a pediatric oncologist, this is something that I think is critical for our patient population, because these are the small individuals who have decades of life ahead of them, and who we really do a disservice to if we allow them to accumulate toxicities from various agents over the course of treatment for many cancers that they are susceptible to getting. And I think we can also think about this in two ways. When you think about the maximum, the cumulative doses of chemotherapy, there are maximums to these drugs that you can get. And these are lifetime maximums. So if you reach your maximum of a certain agent, for example, an anthracycline, when you are 2 or 3 years old, because you've been treated for adrenal-cortical carcinoma, your physicians will be challenged to find alternate therapies if you develop a cancer later on in life that is usually treated with that class of medications, because there will be a risk that your heart, in this particular case, will not be able to tolerate more of that medicine. And so in this sense, you're impacting the treatment, the ability to give effective treatment for future cancers. And we've heard a lot over the past few days about the very important consideration of potentially impacting the risk of second cancers in these individuals. And I think when we think about this globally and where, governments and insurance providers want to hear things, I think this would be a very strong argument in support of surveillance if we could demonstrate an impact on morbidity, because this would make a really big impact on a cost-effectiveness analysis as well. When you think about these individuals moving forward, if they're loaded with toxicities early on from treatment of advanced cancers, those individuals are going to be in hospital a lot. Those individuals are going to potentially not be able to be contributors to society in a way that they might have been potentially without all of this exposure that they had early on in life. And so with that, I'll express the opinion that our aim should be to minimize treatment-related morbidity in LFS patients. And this impact of surveillance is something that we hope to evaluate in our data set soon. So here's just a few examples. This is actually our family of Jonathan Finley's from the CHLA. This is Abella, and this is her brother Hudson. And Hudson was diagnosed with this brain tumor. This is called a choroid plexus carcinoma. And the family didn't know they had Li-Fraumeni syndrome until Hudson presented with this tumor. So he was the original case in the family. And as you can see, this is a very large tumor, and he was very sick when he was diagnosed. Because of his diagnosis of CPC, he was tested for P53, and the germline mutation was found, and his sister was found to have the same mutation. And on her first surveillance scan, this lesion was found. And this actually happened to be also a choroid plexus carcinoma. Now, I'm not a neurosurgeon. I don't know if there's any neurosurgeons here in the audience to back me up, but I think many of us will agree that if you had to choose a tumor to operate on, it would be this one and not this one. And so this, really demonstrates this morbidity argument that when you talk about risk of intervention, this is an example of that, which I think surveillance really allows us to have an impact on. I'll also talk a little bit about some other exposures, chemotherapy exposure. So these are 2 children who we follow here at Sick Kids. This is a little girl who was diagnosed with a stage 4 adrenal-cortical carcinoma. Her name is Gwen. Gwen's mom is here in the audience. You might have noticed Gwen's little sister is the 6-month-old who's been attending the meeting and has been paying very good attention, actually. She's very engaged. So this is Gwen, and this is another little boy who presented and has been followed in our cancer genetics clinic as well. And Gwen was the first member of her family to be diagnosed with Li-Fraumeni syndrome. So she presented with symptoms of this adrenal mass. She had advanced pubertal signs, and when she presented, her disease was considered to be stage 4, meaning that she had this big adrenal mass, but in addition to that, she also had some involvement of her lungs, so the tumor had spread up to her lungs. She was treated very aggressively with chemotherapy, and also went on to have a surgical resection of this tumor. And over the course of that treatment, she did have a lot of complications, and Melissa will remember well how worried we were about Gwen many times. But this little girl, speaking about lift and tenacity, was tenacious and has done well, but not without many bumps in the road. So she had multiple admissions for adrenal crises, including 2 admissions to the pediatric intensive care unit, oftentimes being ambulanced into sick kids to go there, sometimes complicated by seizures. And many years off treatment now, she continues to have something we call primary adrenal insufficiency, so that her remaining adrenal doesn't work well to produce hormones, and also primary thyroid deficiency, so she's on supplementation for both of those. If we contrast that to a little boy who was known to have Li-Fraumeni syndrome and who had the same tumor but picked up on surveillance, so as you can see here, this big mass in his adrenal gland, he actually didn't have any symptoms, and when we investigated to see for more subtle signs of advanced maturation, we didn't find any. He needed a little bit of chemotherapy. So he had about 8 weeks of therapy. She required about 8 months of therapy. And he still had some complications of this, but certainly not to the same degree that we supported Gwen through. And he's off of his hormone replacement now. So I'd just like to contrast these 2 scenarios to say, this is also a representation of the impact that we can make. Gwen is doing great now, but we're going to continue to follow her very closely. We're immensely grateful that she survived this very aggressive cancer. She did so well. And this is one where we're not able to say that many times. So we are very proud of how she's done. But I think this demonstrates an opportunity we have to spare some of our children, some of the medicines that she had to take in order to achieve that great outcome. So the other reflection I'd like to share with you is just one that we've also experienced through our series, and that's that of the synchronous or closely metachronous tumors. So that same little boy that we detected this adrenal mass on surveillance, he actually had a rhabdomyosarcoma of his orbit. You can see this bright spot here. This is his looking down on his head from above, and just around the muscles of his eye developed a tumor. And so he was well onto treatment for this entity, and while getting chemotherapy for this entity, grew another tumor at the same time. And this example was one that was quite notable for us, something that was a little bit humbling overall. And what it really demonstrated, and something that we remind ourselves in clinic every day, is the importance of ongoing surveillance during treatment for a primary cancer. And I want to qualify this by saying it, of course, depends on the type of cancer you have and where your patient is in their trajectory. But if you have a patient with a cancer that you expect them to survive from, so you are treating with curative intent, I would make the statement that surveillance needs to continue during this time. We were actually delinquent in doing so with this child. There was a lot going on. He was facing a big surgery to remove not only the tumor, but also his eye itself, and it was a very charged period of time. And so we actually fell behind in our surveillance, and this scan probably came 4 to 5 months too late. And it's still, I'm still reminded every time he comes into clinic that maybe had we done that, had we been more diligent a little earlier, maybe we could have found this when it was a stage 1. Maybe he wouldn't have needed chemotherapy at all. And so those are our lessons that we've carried forward with us and that I'd like to share with you. There are, of course, many downsides to surveillance. You've heard about these over time. We've all experienced them as more and more institutions are carrying out surveillance, and these include both false negatives and false positives. I'm describing here some of the other false negatives that have happened in the time frame between our last report and the present time. So there was a pelvic leiomyosarcoma in a 47-year-old female. This was missed on a previous whole body MRI, but I think an important lesson from this case was that the previous MRI that she had was actually 2 years prior to her presentation, and she had unfortunately missed the one the year before and then came in with symptoms. So I think this is an example of where we have to try to support our patients in being compliant with the protocol that, you know, one can say perhaps if she had not missed her annual whole body MRI, that maybe this tumor might have been picked up at an earlier stage. There was a prostate cancer missed as well, a young female with bilateral DCIS, which was picked up on prophylactic mastectomy. She had had a breast MRI about the same time, and the interpretation here was non-specific based on breast enhancement. That was noted on that scan. And I think this speaks to the fact that perhaps we can hope that our knowledge will increase over time in terms of how to interpret the signals that we're seeing on these images and getting a little bit better with respect to knowing when to intervene and when not to intervene. And then in our institution, we also had an individual who had an osteosarcoma develop in her mandible. This was not seen on her whole body MRI 5 months prior. In retrospect, looking back, there was a signal there, but not specific enough at the time to call. And this was in a previous radiation field for a rhabdomyosarcoma that she had had of her face as a young child. The false positives, I'm not providing numbers here, but we've all also gained this experience that they are significant in number. This is a huge issue with surveillance. This is something that we see all the time, particularly with whole body MRI. There's always a non-specific signal that lights up on whole body MRI every single scan that we have. One thing that I would note, though, is that I think as a group, when we talk about reporting false positives in the context of Li-Fraumeni syndrome involving imaging that is really looking across the whole body, that we really focus on those lesions where the investigator considers what they're seeing to be potentially neoplastic. In other words, I think we are exaggerating our false positive numbers by including things like a Chiari malformation, things that are part of someone's anatomy or health that happen to be picked up, but really no one would ever think that that's a tumor, and they're not going on to investigate it because they think it's a tumor. It's just something else that the individual has. And so I don't think we should count things like that against the protocol. Similarly, things that are common other growths that have very specific radiographic features, something like an FNH of the liver. We see those all the time, and they're not lesions that we necessarily chase. We might follow up with one ultrasound just to get a more specific image if it's picked up on a whole body MRI, for example. But these are not the types of things that we're going to go and biopsy and worry about. And similarly, at the other end of the spectrum, I'm sure many of you have seen the very nonspecific bone hyperintensities on whole body MRI. Very rarely do we go after one of those. And so I think you really have to look at how people are interpreting these lesions, and really the ones where you are going to follow with imaging or you are going to bring to biopsy, those are the ones that we have to focus on and count as being the true, quote, false positives. And those are still significant in number. I'm not discounting that, but I think we have to be a little bit more specific with the lesions that we're talking about. So just to review some reflections from that slide, I think about the patient and the healthcare provider level, talking about compliance and the importance of that. And this is something that is easier said than done. I think especially with our adult patients, the concept of surveillance fatigue developing over the course of one's life is a really real one. Someone reflected that people are very engaged and enthusiastic to have their children surveyed, and we certainly see that in our institution. But we actually do have a few parents who bring their kids diligently every 3 to 4 months and never go to surveillance on their own when they have the same mutation as their child. And so we have to support them through that. There can be a lot said about the sensitivity and specificity of imaging. I'm not going to say too much because my wonderful colleagues from radiology are going to be speaking after me. But I think there's a bright future ahead of us in the way of incorporating novel techniques and sequencing into some of the MRI imaging that you'll hear a little bit more about. And I think there is a true impact of experience on the interpretation of these scans. So I think every center will go through a bit of a learning curve in interpreting some of these images, and with that, I think issues with false positives and false negatives will get better over time. And I think we have to remember as well, Dr. Evans made this point yesterday, that specifically with respect to false positives, you'll see a greater amount of them on a prevalence scan, but as you continue your surveillance protocols longitudinally, these should go down with incident scans because you find most of the stuff at the beginning. So just some parting thoughts to wrap up. I think, we are enthusiastic about surveillance at our institution, but we recognize that there are challenges with it. We recognize that there are cases where it doesn't meet our needs, our expectations, our hopes. There are some cases, like our patient who developed an osteosarcoma in her radiation field from her previous rhabdomyosarcoma, where we think maybe we're doing too little. Maybe for patients who have had radiation, maybe we need to do focused surveillance of that area at some interval. And is that just layering on too much more intervention for them, or is that something that's prudent? Is it too much for some families? This is a family that we also hold very dear to our hearts. I don't have to explain this pedigree to you. This is awful luck to have every child affected with Li-Fraumeni in a very, very penetrant form of it. A 2-year-old with neuroblastoma, a 3-year-old with medulloblastoma, a 14-year-old with osteosarcoma. Their brother came through our clinic, and this boy was so engaged and very diligent with surveillance, and we surveyed him for 18 years, and nothing came up over 18 years. And then he was the one who on his 18th birthday had his chondrosarcoma. And so if you were ever to suspect a family who you have to intensely survey, it's this one. But this boy, for some reason, was fine throughout all of his childhood. And as he graduated, I felt a little sad that we had put him through all of this for his entire childhood, and really his journey was maybe just beginning at this age. So how can we get better at that? His father, incidentally, the black mark didn't come up, but he got a multiple myeloma at 53, and that was his first cancer. So how do we figure this out? If you look at this individual, I didn't draw the whole pedigree, but if you look at the family tree, you would not have expected that this would have been the case for these kids. And so it's families like this that remind us that we don't know enough to pick and choose to figure out who to survey and who not to. And so I think respecting what cancer is and the impact it can have on these families, I think we are certainly overdoing it for some people, but at the present time, we have a practice of erring on the side of caution. I think we're going to have to be a little bit more cautious over time. Dr. Garber presented very nicely, and others have articulated it as well, about new prevalence information that we're going to be gathering, these new variants that are going to be coming out, and do we have to apply this intensive surveillance protocol to all of them? I think the answers there are probably no, but how are we going to figure that out? I think ultimately our goal will be to get it just right. So too little, too much, just right. Goldilocks concept. When you work in a pediatric institution, everything has to be about a nursery rhyme or something like that. So the just right is something we can maybe call precision surveillance. So the right surveillance onset, the right frequency for the right patients based on their genetics, their P53 mutation and their modifiers, and their exposures. Have they had radiation, and do we have to pay attention to those areas a little bit more? And the right technologies to balance diagnostic accuracy, burden, and cost, and a lot of this work is ongoing as well. You'll hear a little bit about circulating tumor DNA from Dr. Trevor Pugh coming up. That is something that I think holds immense promise for our institution to really make surveillance much easier, hopefully, in the future, while still being very efficacious. And so I think the future is bright. I think we have a lot of opportunity to get better, but I've been excited by this meeting, and I think there's a lot of promise to get there fairly soon. I'd just like to thank everyone here that has supported us through this. First and foremost, the Li-Fraumeni families that we follow in our institution and across our collaborating centers, really incredibly engaged and so willing to participate and contribute in any way that they can. All the members of our cancer genetics program here at Sick Kids, of course, Josh's group in Utah, and Dr. Finley and his families, now at Nationswide, previously CHLA. And I'll end there. Thank you.